Hello and welcome to today's web chat about pregnancy and heart health. My name is Ed Bottomley with the Michigan Medicine Department of Communication. According to the CDC, over 60 million women in the United States are living with some form of heart disease. Heart disease is the leading cause of death for women in the US and can affect women at any age. For women who have heart disease and contemplate having a baby, pregnancy can put their heart under significant strain. Our goal today is to provide helpful information for those who have a heart condition and are thinking about becoming or already are pregnant. We'll talk with our experts about heart health before, during, and after pregnancy. Let's introduce our panelists in a moment, but first, just a few housekeeping items. You can submit questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that your name or profile name will be visible to others participating. If you prefer a more anonymous option, you can send us a private message via the social media channel you're watching on. If you can't stay for the whole chat or want to share the recording with a friend, a video of the chat in its entirety will be available on our Michigan Medicine social media pages later today and also posted to the Michigan Medicine YouTube channel soon after. At this time, let's have our panelists introduce themselves. Dr. Cotts, if you could introduce yourself.
Sure. I'm Tim Cotts. I am one of the cardiologists here at Michigan Medicine. I work with the Adult Congenital Heart Program. I am both in adult cardiology and pediatric cardiology. My area of specialty is patients with congenital heart defects, and I also work very closely with the cardio-obstetrics program in the care of our pregnant patients here at Michigan Medicine.
Thanks so much. And Dr. Langen?
Thanks. I'm Elizabeth Langen. I am a maternal-fetal medicine specialist, which means I take care of pregnant people who have complications either because of the health of the pregnant person, the fetus, or something unique to the pregnancy. And my area of interest is taking care of people who enter pregnancy with heart disease or develop new heart disease during their pregnancy. And have the pleasure of working with Dr. Cotts and lots of other colleagues from cardiology as well as anesthesiology.
Well, thank you both. It's a pleasure to have you here. Let's open up the floor for questions now. I'd like to remind our audience that you can submit questions by commenting on this video, but again, please note that your name or your profile name will be visible to others participating. If you prefer that more anonymous option, you can send us a private message via the social media channel that you're watching on. So let's move to our questions. The first one I'm going to ask to you, Dr. Langen, and it reads, is it safe to get pregnant if I have a heart condition?
That's an excellent place to start and a really complicated question. Whenever somebody asks me if it's safe to get pregnant, it really depends on kind of how safe they want things to be for their health. Pregnancy is always a risk factor to any person's health. You're always more likely to have medical problems and or die the year that you're pregnant versus a year that you were not pregnant. But how significantly elevated those risks are really depend on what medical condition the person comes into pregnancy with. So be it a heart condition or something else, we always ask, how might pregnancy affect this medical condition, and how might this medical condition affect a pregnancy? And we ask those same questions for people who enter pregnancy with a cardiac condition. So we really think about what their specific diagnosis is and how that back and forth interplay is going to carry out throughout their pregnancy, and try to give them a sense of, do they have a small added risk to getting pregnant compared to the general population? Or is their heart condition something that's serious enough where we might recommend other options to pursuing parenting, like surrogacy or adoption?
Thank you. Dr. Cotts, I don't know if you have anything to add.
Yeah, certainly I would add, just as Dr. Langen said, it really is dependent on the patient's cardiac status. And, as I take care of patients with different congenital heart problems, it really depends both on what the patient's congenital heart problem is, as well as the patient's current status with that particular heart problem. So we end up doing a fair amount of individualized counseling for patients based on what their heart problem is. there's various medical manuscripts and publications which develop risk scores for patients based on different heart problems. When we apply those to some patients, but mostly it's applying our experience and our individual evaluation of different patients. So it's going to be very dependent on specific cardiac conditions. I think one thing to say is we can see, as a general rule, we certainly see some higher risk for cardiac events over the course of pregnancy. The risk for very, very serious events with pregnancy is fortunately very low. And obviously the most serious event would be dying during pregnancy. And even patients with complex heart problems, that tends to be relatively low. The patients who we consider at the highest risk are going to be many patients who we would have discouraged pregnancy from in the first place. So one of the key things, and we'll talk about this, I think, over the course of the session today, is really doing a good evaluation of a patient's status prior to pregnancy so we can give a really good recommendation. So I'll sometimes say there's two ways I can find out about a patient considering a pregnancy. One is them saying, Dr. Cotts, I'm thinking about this pregnancy over the next 6 to 12 months. Do we need to do anything advanced to make sure I'm good? Or I can get a call saying, Dr. Cotts, I'm 20 weeks pregnant. And so, obviously we prefer the first. And so we really try and have our patients of childbearing age to know some of the risks up front so that we can get a good counseling session prior to a pregnancy.
Thank you both for answering that question. The next question we have up reads, can pregnancy make my heart condition worse? And Dr. Cotts, let me push that to you first.
Sure, that's another good question and probably not a completely straightforward answer. And there are some heart conditions we can see, especially heart conditions where there is decreased heart function, where we can see the heart function get somewhat worse during pregnancy. There are some patients in that situation where the heart function recovers after delivery. And what we really worry about is certain situations where we can see the heart function get worse and not recover. Specifically from a standpoint of congenital heart disease, there are certain conditions where a patient is born with a right ventricle that pumps to their body. Either they're born that way or if they've had a heart surgery that makes them that way. We know from the scientific literature that certain patients with that type of problem can have situations where their heart function gets worse and does not always recover. So that I think is the answer. So there are certain situations where we would worry about that. I'd appreciate if Dr. Langen has anything to add on that particular issue.
Yeah, thank you. So pregnancy demands a lot of a human being. I think when we see images of pregnant people in the media, we see someone who looks beautiful and just happens to have a bigger belly. And so sometimes we think the only thing that goes on is you gain weight in your abdomen during pregnancy. But pregnancy is really a full body change to your physiology, and everything is working a little bit harder while you're pregnant. So in the cardiovascular system, we think about the fact that your heart has to pump extra blood out. There's more volume in your circulation. You've got this ever-expanding organ in your abdomen that needs more and more of your cardiac output. So pregnancy is a challenge to all of our physiology, but certainly our cardiac physiology as well, which is why it's really important to let folks with underlying heart disease make a choice about when they want to get pregnant and to really be able to be prepared for that pregnancy by working with their cardiologist and or high-risk obstetrician to optimize their health before they get pregnant and also optimize whatever medications they might be on so that they're taking something that's safe to continue throughout their pregnancy.
Thank you both for those answers. The next question we have was something that we touched on with regards to question 1. It reads, are some pre-existing heart conditions particularly high risk? Is there anything you want to add on these conditions that are particularly risky? And I can go to you first, Dr. Cotts, if there's anything.
Sorry, my unmute didn't work the first time. So, I would say there are a couple issues, and I think Dr. Langen can help with this as well. There's one particular that I think we may talk about a little bit later as well. Peripartum cardiomyopathy is a heart problem that occurs around the time of delivery, and where we see that the heart can get sicker around that time. And it is very important in evaluating the patient after as to whether their heart function gets back to normal or not after a diagnosis of peripartum cardiomyopathy. If a patient has peripartum cardiomyopathy and their heart function remains decreased after the pregnancy and after recovery, that patient was quite high risk for getting sick with additional pregnancies. And so that is one particular area where we would have very specific counseling. And Elizabeth, would you add anything about that?
I think that's an excellent point. Other things that I think about when I think about folks who I really worry about them having a pregnancy are people who have, connective tissue disorders that may make some of their really large blood vessels have a challenging time handling all that increased blood volume of pregnancy. Folks who have a condition called pulmonary hypertension are also at particularly high risk for complications in pregnancy. And so I would say anyone who has any of these conditions, be it a history of peripartum cardiomyopathy or the other things that we've talked about, I really advocate that you talk to your primary cardiologist about pregnancy, even if it's not immediately on your radar, because oftentimes in those visits, you're so focused on your cardiovascular health. Sometimes people forget to ask about reproductive health and things about, contraception and other ways to help you avoid pregnancy until you are ready to make that choice for a pregnancy. And I know Dr. Cotts and his colleagues do an amazing job of always counseling folks on that. But some folks who don't necessarily take care of pregnant people all the time might miss that from their clinical exam. So it's important for patients to think about how to ask for those services and how to get access to that if they need it.
I think I'll just add one more thing there. And Dr. Langen stated there, the list of heart problems where we really think pregnancy is high risk to the point where we would discourage it. Again, that list is quite short. And I'm going to wrap those things up. But again, one of them was patients with connective tissue disease, and especially those with very large aortas. Pregnancy would be quite high risk. The other is pulmonary hypertension, as Dr. Langen said. The other is patients who have depressed heart function with low ejection fractions in symptoms, what we call New York Heart Classification 3 or worse, which means essentially you get short of breath walking across the room. Those are the relatively short list of heart problems where we are very, very concerned about pregnancy risks and might discourage a pregnancy.
Thank you both for answering that. The next question I'm going to pass to you first, Dr. Langen, and it reads, as it relates to age's effect on pregnancy and heart problems, is there an age at which pregnancy is no longer recommended?
That's an excellent question. For a general population, we know as folks get older, they are a little higher risk for having some cardiovascular complications of pregnancy. More common things like preeclampsia, especially, are more common as folks get older. So we do take that into consideration. I would say for folks who have underlying heart disease, it can be different depending on what that disease is. For some folks, as you get older, your heart may deteriorate over time. So it may be better to get pregnant when you're younger and you have better cardiovascular functioning. But I certainly take care of some people who do need some intervention. They may need some type of surgery or valve replacement. And in that case, it may be worth having your cardiovascular status optimized, even if it means you're going to be a year or two older in your pregnancy, because having a better cardiac function when you start pregnancy outweighs any added risk from a year or two that might be necessary for that surgery and recovery.
Thank you for that. The next question that we have coming up, is there a time during pregnancy when the risks are higher? Dr. Cotts, I'll pass to you first. Sorry.
Yeah, sure. I can start with that. So what we see is there is some increased risk, over the course of pregnancy. A couple points I would make is Dr. Langen talked really nicely about the increased demands, and a lot of those things start to plateau a little bit at around 20 or 24 weeks. So we can see that over the course of the pregnancy. A lot of the risks we can see associate a time of labor and delivery. But one thing I really want to say is that the risk does not completely go away at the time of delivery of baby. The one thing that does happen certainly is we can see around the time of delivery, there is a lot of shifts that occur within the system as the placenta is no longer part of the circulation. So that part we can see changes suddenly, but we also worry about the first week or 2 or 3. So the early postpartum period, a lot of people are very happy once the baby is born, the baby's okay, the mom is okay, and there's a lot of relief at that particular time. But I think Dr. Langen and I don't completely take a deep breath out until we get past that first week or 2 as well. So I really like patients to hear that we do have some concern, and I really like to hear patients after they deliver over that week or so that things should be getting better and not getting worse. So if you have a woman who goes home and over the first several days or first week, it's not too uncommon around the delivery to retain a little bit of fluid. We see that, but over the first week or so, that should be getting better and not getting worse. So if a person is getting more fluid, more short of breath, we don't want them to be sitting at home languishing and having trouble. We want to know about that, and we want a patient to know, yes, that could be sign of trouble that we would want to worry about. So we've seen this before, and so I would really, take-home point I would say is that we certainly see risk during pregnancy, but we also see some risk in the early postpartum period. So we really want patients to know that they're not completely out of the woods at the moment of delivery of the baby.
Thank you. I don't know if you have anything to add, Dr. Langen.
Yeah, I would just reiterate what Dr. Cotts said. While you are currently pregnant, you're coming to see your obstetrical team very frequently. We're checking in with you all the time. We're asking about your symptoms. So we have a pretty good pulse on how you're doing. While you're still in the hospital and birthing the baby, you've got all these folks paying really close attention to you. And that postpartum time, if you look at maternal mortality statistics from the United States, that's the time when people tend to get into trouble. So I would say to folks, not only paying really close attention to all the symptoms that Dr. Cotts mentioned, but if you do end up going in to be seen at an emergency room or someplace other than where you got your obstetrical care, it's really important that you highlight to those emergency room folks that you were just pregnant, because that changes how they think about you, and then let them know who your cardiologist and obstetrician are so you can get some continuity of care.
Thank you both for those points. The next question that we'll move on to, I know we've covered this a bit, but is there anything to add for this one? It reads, what should I do if I want to get pregnant and have a heart condition?
I can start with that one.
Yeah,
if
go
that's
ahead.
okay. Yeah, I think the first thing is to check in with your cardiologist. And, if anytime we're seeing a patient of childbearing age, it is my job to kind of bring this up and ask them myself, but we also need the patient to advocate themselves. And if something that they're planning, I think it's really good to bring it up at your regular cardiology visit. If you can't wait till the next cardiology visit, make a special appointment. Because what we would do is we would have a very specific conversation and we do a good evaluation to make sure that you're a good cardiac status. Dr. Langen talked a little bit about maybe needing cardiac procedures or things like that first, but we really want to make sure the patient's as good as they can be. So sometimes we'll recommend make sure we have either a recent echocardiogram, a recent cardiac MRI, or exercise test, or other things. So I would say, and we also, again, want to make sure that a patient is in really pretty good shape, has a good functional status, and doesn't have any symptoms that we would worry about. The other thing is that we would always consider, and I think we'll have a specific question related to maybe to medications later, but we would always want to go through medications and make sure that medications a patient is on are safe for pregnancy at that time. So I would say really the short answer to the question is talk to your cardiologist, say you're thinking about it, so we can go through and make sure that everything's in good shape.
Yeah, absolutely. I agree with all of that. I will say that most cardiac medications are safe to continue in pregnancy. And so don't just stop everything. If you have a positive pregnancy test, call your cardiologist. There are a couple classes of drugs which we would switch, but most of them should be continued. And the other thing I would say is just make sure you're taking some supplemental folic acid or a prenatal vitamin. That's my general obstetrician pitch.
And I'll just add to that as well is that We have a very specific process where we do what's called preconception counseling, which is where we talk to a patient prior to getting pregnant. We can do that as cardiologists. I think that if you are out in the community, some cardiologists will be more comfortable with that than others, and you may need to see a specialist, especially if you have a complex heart problem. The other thing that we will sometimes facilitate as cardiologists is to have the patient have a conversation with Dr. Langen or someone like her. And I'm really good at talking about the cardiac issues involved, but sometimes if a patient has non-cardiac issues that impact the pregnancy, Dr. Langen's group will have a lot of expertise, and they'll be able to, I'm pretty good about talking about what this pregnancy would look like for a patient, but Dr. Langen can give the OB side of things as well. So we can have a specific preconception counseling visit, either with a maternal fetal medicine specialist or with a cardiologist. So those are all things that can occur prior to pregnancy.
Thank you both for answering that question. The next one we have up, I'm going to pass to you first, Dr. Cotts. It reads, if I have a heart condition, will my baby get it too?
That's a really good question, and it is something that we will try and talk about at that preconception visit and in talking to patients about this. Again, this is going to start. I had a mentor who answered every question by saying it depends, and so I will say it depends on the heart problem. And there's something we talk about specifically. And generally speaking, the risk of having a baby with a heart problem is about 1 out of 100 or so. And so in the general population, that's the risk we would counsel. We know that patients with congenital heart defects specifically will have a higher risk of passing these on. Generally speaking, the risk is a little bit higher if the mother is affected than if the father of the baby is affected. So we would see that. And in general, and this is a very rough saying, generally speaking, if we say the risk in the general population is about 1 out of 100, for babies having heart problems, if the patient generally averages around 2 to 3%. So the risk is a little bit higher, but it's still not absolutely very high. There are some specific congenital heart problems and genetic syndromes that are passed at a much higher rate. There are things that we are called autosomal dominant, meaning that they are passed on with essentially a 50-50 chance of being passed on. Things like Marfan syndrome. There are congenital heart defects associated with something called DeGeorge syndrome or 22q11 deletion syndrome. Those are 50%, and we really do a lot of counseling for families with those particular issues. Common things like tetralogy of flow, the ventricular septal defect, those tend to be that 3 or 4%. So a little higher than the general population, but still relatively low. And then what we do recommend in those cases is that the woman get what we call a fetal echocardiogram, which is done at about 20 weeks gestation or so, depending on the place. And we can do a pretty good job at making sure that baby doesn't have a complex congenital heart problem. There's some tough things to see on that fetal echo, but it's really pretty good. And, the anatomy scan that will be done by the maternal fetal medicine specialist is quite good, and it can see a lot of major heart problems. The fetal echo gives an additional level of detail that we can see.
Thank you. Let's move to our next question, which I'm going to pass to you first, Dr. Langen. How to relieve chest tightness during pregnancy?
That's an interesting question. And what I would say is, chest tightness is a symptom that if you were having that and it was new, I'd want you to reach out and talk with your obstetrician about it. One of the challenges in taking care of folks who have underlying heart disease is a lot of the symptoms that go along with having cardiovascular events are also the same symptoms that go along with having a normal pregnancy. So you can have some shortness of breath from walking up a flight of stairs just because you're pregnant or because you're having decreased cardiac function. You can feel some burning in your chest because of acid reflux, which is very common in pregnant people, or because you're actually having some harm to it can be a cardiac cause of that chest pain. So I think what's really important is for these folks to have a great relationship with their both obstetrician as well as cardiologist. This, as you've noticed, is a really team-based approach to care. And if the chest tightness is something that's new or different, it's important for folks to talk about with their care teams and not just kind of brush it off and say, well, I guess it's just because I'm pregnant. If people have underlying heart disease that places them at higher risk for cardiovascular complications, we really want to hear about their symptoms so that we can figure out what we need to do to evaluate it and then come up with a treatment plan.
Thank you for that, Dr. Langen. Let's move on to our next question here. And this one is centering on what is a normal heart rate during pregnancy? Does your heart rate increase when pregnant, and why? And what is a dangerous heart rate for a pregnant woman? Happy to go through those questions again because there were pretty much 4 of those in there for you, Dr. Langen. But what is a normal heart rate during pregnancy, and what is a dangerous heart rate for a pregnant woman?
Yeah, so everyone's heart rate does increase in pregnancy. It's part of the way your physiology adapts to being pregnant and to continue to circulate that higher blood volume. So your heart rates tend to go up about 10 beats per minute, and a normal pregnant person can sit with a heart rate of up to 105 beats per minute, and that can be very normal. There's not a specific number where we say, gosh, if you get to this number, that feels dangerous. But what we like to pay attention to is kind of what's changed for that individual patient. So if this is a person who is athletic and typically has a heart rate in the 70s and it's in the mid 80s or 90s while she's pregnant, that feels very normal. But if her heart rate is all of a sudden in the 120s without any provocation, that's something we do want to investigate a little bit more. We know that being pregnant in general for anyone puts folks at a higher risk for having arrhythmias. And especially for some folks with certain types of underlying heart disease, they may be at particularly high risk for developing cardiac arrhythmias. So folks are noticing an abnormal heart rate, which I will say often happens because folks' Apple Watch or other devices alerts them to an abnormal heart rate. It's something that, again, we really want folks to reach out, share those symptoms with us, and then we can do a more thorough evaluation depending on the symptoms that are associated with that change of heart rate and their underlying heart condition.
Yeah, and I'll just add and agree with everything that's been said. As cardiologists, we always differentiate a little bit between what's called normal sinus rhythm or sinus tachycardia, which is the heart it's doing its normal thing, but maybe a little faster than usual, as compared with a patient being in an arrhythmia or an abnormal heart rhythm. And that's the type of situation a patient could just be sitting there doing nothing and their heart rate's going 140 or 150. And that would be something that should prompt an evaluation. And so generally speaking, if we have a patient either having palpitations or having a fast heart rate, what we really always want to know is what the patient's heart is doing when they're feeling that. And so we'll usually do some sort of a heart monitor. We can bring a patient in to get an EKG and confirm what the heart rhythm is. Some Apple Watches and other gadgets at home will start to create EKGs now that we can send to us. But I always like the patient to come in and get a real EKG so we know what's going on. We also have heart monitors that we can use at home or in the hospital to figure out what the rhythm is.
Thank you both for that. Next question, I'm going to send it to you first, Dr. Cotts. Can pregnancy cause heart palpitations? How do we stop heart palpitations during pregnancy? I know we touched on this, but is there anything else you want to answer or anything else you want to add?
Yeah, I can add a little bit. Palpitation is actually a funny word. And I think, what does it actually mean? And I think a palpitation I would describe as somebody feeling a funny heartbeat. And it can mean that a patient can feel a flip-flop or a skip. It can mean a patient is feeling a very fast heartbeat. So the first thing when I hear the word palpitation, as I said, well, what do you mean by that? Are you feeling a skip? Are you feeling a flip-flop? Is it just going fast all the time? And so certainly we can see in both normal patients and patients with heart problems where, as we said, the heart gets a little revved up, so patients can feel the heart going a little faster, but we can see a higher risk for those arrhythmias. And so we can see patients who have never had a premature ventricular contraction or a PVC until they have pregnancy. And then we see that goes away with pregnancy. So those are things that we watch. I'll just talk a little bit about PVCs because it is something we can see sometimes. patients feel a flip-flop. And what happens is what the bottom chamber of the heart fires a little bit early. You don't feel that heartbeat because the heart hasn't really had time to fill yet, but you feel a little bit of a pause and then a very hard heartbeat because now the heart has had all this time to fill and beats a really strong heartbeat. So patients feel this pause and then a wham. And so if I hear that, I usually, yeah, that sounds like a PVC. Those are usually benign, but it's something we would want to know about. And sometimes we figure out if they're happening really frequently, it can be a little bit of a problem. But most of the time, that's pretty common. It's usually not a problem, but it's something we want to figure out and something we want to know about.
Dr. Langen, I see you nodding. I don't know if you have anything to add.
I agree with all of that. It's something that, is a tough symptom that lots and lots of pregnant folks have. So we like to evaluate kind of what exactly are you feeling? How are there symptoms associated with it? Are folks getting lightheaded, dizzy, fainting? And so we do try to take a history to figure out what's making that funny sensation in folks' hearts and look not only at the heart rhythm, but also other things that can make your heart a little bit irregular, like profound anemia, which can happen in pregnancy, or alterations to your thyroid function. So it is a common thing, but there can be some underlying medical issues for that symptom. So we do appreciate hearing about that.
Thank you both. Oh, Dr. Cotts, did you have anything to add?
Yeah, I thought maybe we could talk a little bit about caffeine. That just made me think about caffeine if people, and I don't know if you have specific, what we know about caffeine specific from a heart problem, caffeine has been implicated in a lot of horrible heart problems. In general, there's very little data that caffeine causes arrhythmias or abnormal heart rhythms. What we know, it revs up the heart and makes it go a little faster, and patients feel a lot more palpitations when they get caffeine. But it doesn't really tend to cause specific arrhythmias for the most part. So I don't know if you had any specific recommendations on caffeine for pregnant patients with or without heart problems. Dr. Langen.
Yeah, caffeine is a very controversial topic in pregnancy world. There's been some concern about, does it cause any harm to the fetus or increased risk of miscarriage and things like that. What we generally tell most pregnant folks is 2 cups of coffee a day or the equivalent of that is totally fine. That's well within the safe amount of caffeine to take. If people notice that caffeine is triggering to their body or their physiology, sometimes folks will stop that. But people do not have to stop all caffeine just because they're pregnant. And most people are very happy to hear that.
Yes, thank you both for that and for the spin-off question on caffeine. I'm going to pass the next one to you first, Dr. Langen. What medications can pregnant women take with heart disease?
An excellent question. Like we talked about earlier, in an ideal setting, you would talk with your cardiologist prior to a pregnancy, and they can go through with you what medications you're on and if any changes need to be made. A high-risk obstetrician is also very happy to do that before a pregnancy. I would say there's only a couple medications that we are quite concerned about. So there is a blood thinner that's called Coumadin or warfarin, and that is a medication that if someone's taking that very early in pregnancy, that can cause some issues with the fetus, both early in pregnancy and then different concerns later on in pregnancy. But that is a medication that should not just be stopped all of a sudden. It usually needs to be replaced with a different blood thinner. So anyone who's taking that medication for things like a mechanical heart valve, we really encourage them to speak with their cardiologist and or maternal-fetal medicine specialist prior to pregnancy. Or if that doesn't happen and they happen to have a positive pregnancy test, that's an urgent phone call and we will take care of that same day. The other class of medications that we have some concerns about are things that are called either ACE inhibitors or ARBs. Those are medications that we know, especially in the 2nd and 3rd trimester, can cause some issues with the fetal kidneys. And so we strongly recommend that people be off of those medications. They're usually used for blood pressure control, but there are many classes of blood pressure medications that are very safe to use in pregnancy. Now, I will say sometimes folks go to their pharmacy to pick up their medication and the pharmacist says, gosh, are you pregnant? You probably shouldn't be taking this medication. And I think those comments are well intended, but most other medications other than those couples that I've talked about really should be continued in pregnancy. And in particular, there's one class of medicine called beta blockers that some folks have concerns may cause issues with the baby's growth. But when we looked at our data here at the University of Michigan in a study that was recently presented at the Society for Maternal-Fetal Medicine, what we found was that when folks continued to take their beta blockers, they actually had better fetal growth than in the patients who did not take their beta blockers during pregnancy. So what we think is that people who need a beta blocker medication have some underlying cardiovascular disease that might impact baby's growth overall, but that taking the medicine, helping your heart work well, taking care of how your body is working is probably the best thing to do to make sure that the baby is growing and healthy as well. So we really don't want people to just stop their medication all of a sudden. The one exception of the Coumadin, that's an urgent phone call to your local maternal fetal medicine specialist to get switched to something else.
Thank you so much. Dr. Cotts, I don't know if you have anything to add. I saw you nodding along.
Yeah, no, I think that's really a great summary, and I think the beta blocker point is excellent. And these medicines usually serve a purpose for keeping the cardiac status as good as possible. So that's very interesting data to hear.
Thank you both. The next question reads, if I have heart disease, when should I see a cardiologist who specializes in pregnancy? And I'll pass that to you first, Dr. Langen.
So I think, as Dr. Cotts alluded to earlier, ideally you'd see them before you got pregnant. So you could have a good conversation about what pregnancy would look like, how your cardiologist would monitor you during pregnancy, and what symptoms to kind of look out for when getting pregnant. Lots of cardiologists do feel comfortable in this space, but not everyone does. And so sometimes folks, for example, will come down and see some of the cardiologists here at the University of Michigan who take care of a lot of pregnant people, and we'll see them during their pregnancy, and then postpartum go back to their local cardiologist for their ongoing health needs. But I think before getting pregnant is the ideal time. And if that can't be arranged, then we will see you as soon as possible.
Yeah, and I'll add, sometimes we always tell our patients, we say the same thing, but if we also, let us know if you get pregnant, but sometimes they call us and it's, yes, I'm 8 weeks pregnant and we're fine. We don't always need to see you right away. We'll often, it depends on the heart problem again. Often we'll bring patients back in the mid-second trimester to do a good echo to check their heart, at the same time get the fetal echo. And so we like to know as soon as possible, but sometimes it's a little hurry up and wait. And we say, yeah, thanks for letting us know. We'll get you, nothing need to do right now. We're glad we're aware. We can look at the medications, make sure we don't need to change anything. But then often the first visit can be kind of mid-pregnancy.
Thank you both. Just a quick time check for viewers and our panelists alike. We are at 12:38, so we have about 22 minutes left to answer questions, but I'm going to go straight into our next one. I'm going to pass this one to you first, Dr. Cotts. It reads, can pregnancy cause me to have heart failure?
So a couple ways to answer that question. So I think I would start by saying a patient with a normal heart, okay, can you develop heart failure? And that goes along the lines of, we talked a little bit about peripartum cardiomyopathy, which is meaning a decline in heart function around the time of delivery, and so that is a relatively rare, but it is something that we would worry about. And that in that situation, we would really worry about the patient getting, as Dr. Langen nicely said, patients towards the end of pregnancy get short of breath and some swelling in your legs, and working with your medical team to understand, is that worse than normal, to prompt an evaluation. So peripartum cardiomyopathy, the first way to diagnose this is to think about it and to know that to think about checking an echo and making sure everything is okay with the heart. So for the patient with the normal heart, the answer is yes, you can develop heart failure during pregnancy, but I would say it's quite rare, but it's something we always want to think about and not to miss. In a patient with an existing heart problem, there are patients, I would say the highest risk group of patients are patients who we worry about already. So with already some decrease in their heart function. So we think about sending patients for a stress test and put them on a treadmill. The pregnancy is kind of a 9-month treadmill test, so it is a little bit of a stress test. So we can see patients who, especially if they're just a little bit on the edge, that can kind of get pushed over a little bit. And, a lot of patients will say, your heart it's good, it's not perfect. And sometimes I just will say, with your heart, you just may not feel very good the last couple of months. You won't really be in heart failure, but you may be a little short of breath, a little more swelling. We may need to treat that to kind of get you through. So we can see, actually going into severe heart failure, requiring admission to the hospital and getting intravenous medications, that is quite rare. It's a little bit more common to see the spectrum where they just don't, a little more short of breath. Maybe we see some changes in the blood tests that make us change the medications a little bit. And that's what we would worry about. Severe, serious heart failure, and we can predict some of the patients if they have severe heart valve disease, or if they have pre-existing decreased heart function, we can predict some of those patients a little bit.
Thank you. Dr. Langen, I don't know if you had anything to add to that.
No, I think Dr. Cotts covered all the big important points. And, again, just that paying attention to your symptoms, talking with your physician team about how you're feeling so we can try to tease out like what is normal pregnancy versus what is cardiac. Just in communication, always super important.
Thank you. And I'm going to push the next question to you, Dr. Langen. It reads, are there more risks during childbirth for someone with heart disease?
For folks who do have heart disease during pregnancy and birth, birth is a pretty dynamic process and kind of an amazing thing that happens. But it does cause some stress to the cardiovascular system. So we do think about all these patients really carefully. One of the things that I'm very proud of our team for doing is every month we talk about folks who have heart disease and are pregnant, and it's a collaboration of cardiologists, maternal-fetal medicine specialists, anesthesiologists, nursing, social work, and we all talk about kind of not only what's happening during the pregnancy, but what is going to birth look like. And so we talk through for everyone's individual heart disease, what might they be at risk for? What drugs should we avoid that we might typically use during pregnancy? And should we alter their birth plan a little bit because of their underlying heart disease? So there certainly are some added risk to being a person with heart disease who's delivering a baby, but there are lots of ways that we can safely guide people through that process.
Thank you, Dr. Langen. I don't know if you have, it looks like you do, Dr. Cotts, if you have something.
Yeah, I would just add, I think that this developing the delivery plan in advance is extremely important. And I think when you see trouble, it's sometimes because you weren't expecting things. And so that delivery plan really allows us to all be on the same page in advance of delivery. And I think that if we particular patients with very complex issues, sometimes there will be hours of meetings between all of us and several hundred emails sometimes to make sure that we're all on the same page for these issues. But the more you plan it out, the less we are to likely get trouble. And these things tend to go quite smoothly if we've done a good job of anticipating issues that come up. But I think that one really great thing about how we work together is that, I've worked with Dr. Langen, I know at least 10 years. So we really have a pretty good idea of developing these plans together, having an expert anesthesiologist who can really weigh in on all of those things. And so, we're not on call 24/7, but we develop a plan that can be implemented if we're not there. We always have us or one of our partners available, but the plan is made in the light of day with everybody agreeing, and then that plan gets implemented. If a woman goes into labor at 2:00 in the morning, we've got a plan in place so there's no surprises. So that's very, very important part of what we do.
Thank you so much for those answers. The next question I'm going to push to you first, Dr. Langen. What is the birth process like if I have a heart problem? Do I need a C-section? Do I need to deliver at a specialized hospital?
So I try to encourage my patients with heart disease that the birth process can still be something amazing and wonderful and beautiful, just like anybody else's birth process. It doesn't have to be a completely medicalized thing. There have been multiple publications demonstrating that folks with heart disease do just as well with a vaginal birth as opposed to a cesarean birth, with a couple of small exceptions. So there are a couple conditions where we think, gosh, the pushing part of labor where people tell you to bear down to deliver the baby. There are a couple conditions where we worry that, gosh, that might be a little bit difficult for individuals' hearts, particularly if they have a dilated aorta and certain types of underlying connective tissue diseases, or if people have really quite profound heart failure and this is their first birth, sometimes that might be limited. But for most people with heart disease, we generally recommend a normal vaginal birth. While there is sort of the unpredictable nature of vaginal delivery, the recovery from that and the way that that functions in your body tends to be really well tolerated, even for folks who have heart disease. The one thing that we recommend that is a little bit different is we do tend to recommend epidural anesthesia for folks who have cardiovascular disease during labor and delivery. And I tell my patients, it's not that I don't think you can handle pain or discomfort. And a lot of these people have had multiple open heart surgeries, so they certainly have tolerated a lot of pain and discomfort in their life. But having the epidural anesthesia helps get rid of some of the pain, some of the stress response, so can help keep some of their cardiovascular parameters a little bit more even during labor and birth. So I do make that one recommendation, but and we do talk very carefully about what type of monitoring is or isn't needed during labor and delivery. But for most people, a vaginal birth will still be recommended. In terms of where to deliver, Dr. Cotts often says, sometimes we bring folks to the University of Michigan to deliver just so that they are kind of the lowest risk patient on our floor as opposed to the highest risk patient. So we try to avoid doing things to people that they don't need. So again, most people don't need a cesarean delivery. Most people don't need general anesthesia, and we try to provide that for them here.
Yeah, and I'll just add to that, and Dr. Langen knew I was about to say that particular point, so she got it, and so that is great. But certainly there are a lot of patients who just needed to be treated normally. And I think that if there is a woman with a heart problem and they're seeing a provider who seems really uncomfortable or said, yeah, we don't take care of a lot of patients like you, or they're planning on having a surgeon in the delivery room or something unusual, that's a good time to get an opinion from Dr. Langen or me or someone like us, because sometimes we can say, yeah, we do this and this is actually okay. And so there are some times with very complex heart problems where we need to have access to all the fancy things that we have here. Advanced cardiac support, surgery, all of those things, which we have here, but most patients don't need those things. But those are things that can, the things that can trigger being delivered here are either patient needing those things or just needing a physician group who's comfortable with that level of heart problem.
Thank you both for that question. That answer to that question. The next one that we have up, this is an audience question, and I might add, you may need to do a little explaining of some of these conditions, Dr. Langen. And it reads, what preventative measures can be taken for infective endocarditis in patients with ASD planned for lower segment C-section? I don't know if you can see that question yourself, Dr. Langen, or if you want me to read that out again, but it does look like it might need a little bit of explaining.
Yeah, so the question is asking for if someone has a specific type of cardiac defect, a atrial septal defect, do they need specific medications to prevent infection in their heart valves if they're planning a C-section? There is not a clear consensus on whether or not anybody needs special medication to prevent those types of valve infections during birth, be it by a cesarean birth or a vaginal delivery. And in general, the recommendations are that you don't need any specific medications beyond the antibiotics that everybody gets prior to a cesarean birth. In particular, we think about people who have had valve disease in the past and have had this kind of valvular infections in the past. Sometimes we may recommend different antibiotics for them. But that's really the only group of people who, in general, we're recommending anything different.
Yeah, I think the C-section makes that answer easy because it would be standard care. I think there's a little more debate with vaginal deliveries and endocarditis prophylaxis. Specific to atrial septal defect, most patients with atrial septal defect, if they have not had prior endocarditis, don't require antibiotic prophylaxis for most things. If a patient is within 6 months of either surgery or device closure, that would be an indication for antibiotic prophylaxis in general. Patients either with, remotely closed atrial septal defect or a unrepaired ASD generally do not require SBE prophylaxis.
Thank you both. That's one of the wonders of these live chats. We can have you tackle these complex sounding questions. Let's move on to another mini topic here, postpartum. The next question, and I'll pass this to you first, Dr. Cotts. This one reads, what are worrisome symptoms that I should look for after delivery?
Yeah, we discussed this a little bit earlier, but I think it's worth reinforcing a little bit. And I think that is swelling in the legs or anywhere else that is getting worse postpartum, and then really shortness of breath. So shortness of breath, walking around, doing flight of stairs, things like that. Difficulty lying flat would be a concerning symptom that we would want to know about. And then, palpitations, irregular heartbeat, fast heartbeat. I think those would be the biggest symptoms, but it would be, again, symptoms that are getting worse and not getting better after delivery, particularly swelling and shortness of breath.
Thanks so much, Dr. Langen. I don't know if you have anything to answer, to add.
Yeah, the only other thing that I would add is a common complication of pregnancy is something called preeclampsia. And it is a complication where folks get high blood pressure because of their pregnancy, and other organs can also be involved. Certain types of people, anyone is at risk for that. That can happen after any pregnancy. And certain types of underlying heart disease make that a little bit more common. And while that typically happens before birth, it can also happen in the postpartum period. So some of the symptoms will look a lot like the things Dr. Cotts was encouraging people to look out for. But a lot of women now do have blood pressure cuffs at home because of a lot of remote prenatal care that's happened post-COVID. So if folks do feel unwell or different or just not right after pregnancy, I do recommend that they check their blood pressure. And if it is abnormally high, do recommend that they contact their OB provider. And again, if you do find that your blood pressure is abnormally high and you go to someone who is not an obstetrical provider, like an emergency room, it's very important to let them know that you were recently pregnant, because they'll interpret your blood pressure very different in the context of a recent pregnancy versus someone who hasn't been pregnant in the recent past.
Thank you. And let's move to our last question here. I'll pass this to you first, Dr. Langen. Can postpartum depression exacerbate heart disease?
It's a really interesting question. Postpartum depression, I will also say postpartum anxiety is a very common disorder as well that doesn't get as much conversation. And there's also postpartum PTSD, depending on what happened during the labor and birth process. Those are very common mood disorders that anybody can have after delivery. And it's important to pay attention to those symptoms. And I also encourage people's family members to be aware of them and looking for those symptoms. So we don't know of any like medical correlation that if you have this type of depression, that's going to impact your heart disease. But having this type of depression, anxiety, or other mood disorders might impact how much attention you're able to pay to your symptoms, how much energy you have for reaching out to your healthcare providers if you do have some of those symptoms of swelling or palpitations in your heart. So it might delay the diagnosis and treatment of some heart disease. So I think bringing up those very common mood disorders, making sure that all pregnant people and their support systems are aware of it so that if those are going on, we don't lose track of other symptoms, I think is important.
Yeah, and I'll just add that patients with heart disease, particularly patients with congenital heart disease, do have somewhat higher risk of underlying depression and anxiety than the general population. So that is out there, and it can be exacerbated during pregnancy and the postpartum period.
Dr. Langen, Dr. Cotts, thank you so much for your time answering these questions. I always like to ask at the end of these live streams, is there anything that you think we've missed? Dr. Langen?
I think we've talked about a lot of the key points. Just to reiterate them, talking to your healthcare team before getting pregnant is ideal. Talking to your medical team about ways to choose the timing of your pregnancy is also super important. And if that's not something they feel comfortable doing, we have lots of services in our Advanced Family Planning Center, which can help with those options. I would also encourage folks to, make sure that you find a healthcare team that, one, feels comfortable taking care of you while you're pregnant, and two, you feel comfortable really having good communication with, because that will help you do as well as you can during pregnancy. And then again, to reiterate what Dr. Cotts really importantly emphasized in the beginning, you're not totally out of the woods of pregnancy complications until we get a little bit beyond the postpartum period. So even though you've gone home from the hospital, if symptoms are worsening, if blood pressure is worsening, those are important times when we know a lot of complex complications can happen. So please reach out during those times so that you can get the same quality healthcare after birth as you were getting during your pregnancy.
Thank you. And I'll pass to you now, Dr. Cotts.
Yeah, I think we were really able to say everything we wanted to say through those questions, and then with Dr. Langen's wrap up as well. I think just again emphasizing, that both the patient and the physician team should be comfortable, and that patients with the more complex the heart problem and everything else, the more you need a comprehensive team of people who are really comfortable and make these decisions together commonly. And I think that having the experience of working together, we really are able to get good plans for our patients through the process, including very complex situations.
Thank you so much for those final thoughts. We're closing in on the end of our chat together today. So Dr. Cotts, Dr. Langen, thank you both for sharing your time and expertise with us. Both of our panelists work out of University of Michigan Health in Ann Arbor. To make an appointment, you can call 734-763-6295. And I'll repeat that, 734-763-6295. And information about their clinics is also available at umcbc.org/cardio-obstetrics. That's umcbc.org/cardio-obstetrics. Thank you to our audience for spending part of your afternoon with us. We hope today's chat has been helpful. And if you're interested in sharing the recording of today's chat with others, you'll find it on the Michigan Medicine social pages later today, and also on the Michigan Medicine YouTube channel shortly thereafter. Again, thank you for joining us and have a wonderful afternoon.